Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it's my great pleasure to welcome Dr. Farron for this interview. Dr. Farron, thank you so much for taking out time to join us today.
Thank you for having me, Dr. Klee.
Yes, sir. So today we are very excited to feature a publication titled Outcomes After CABG Compared with FFR-Guided PCI in Patients Presenting with Acute Coronary Syndrome. So Dr. Farron, when you first presented the initial FAME3 results, the analysis in the TCT 2021, at that point, we learned that CABG demonstrated lower clinical event rates compared to FFR-guided PCI at the 1-year mark. Non-inferiority of PCI was not achieved, and there was some discussion whether the non-inferiority margin was set too high. With this context, Dr. Farron, could you walk us through the design of your current analysis?
Yes, sure. So the original primary endpoint, including death, stroke, MI, or repeat revascularization at 1 year, was established because we wanted to kind of mimic the syntax trial and then be able to compare the results using fractional flow reserve to guide the PCI and using current generation DES. And so we did the same non-inferiority design. And when we planned it, we expected similar outcomes in the CABG arm as was achieved in syntax. But during the course of enrollment in the study and as we were going along, other studies came out like Excel and Noble, and these had lower event rates in the CABG arm and the BEST trial too, suggesting to us that maybe we had overestimated. And because we weren't using an absolute non-inferiority margin, we were using a relative hazard ratio, we felt that it was reasonable to adjust the non-inferiority hazard ratio because of these different lower event rates. In addition, we were including repeat revascularization, whereas other studies like Excel were focusing on, say, death, stroke, and MI, and they had used a fairly large non-inferiority margin. And so I think, when you establish a non-inferiority margin, it's based on basically any precedent and clinical consensus as to what you would accept. And if you're including repeat revasc, you probably have a little broader acceptance, rate. And so that's the background. In the study that we're now talking about, we're looking at 3-year event rates, and these were pre-specified analyses and just focusing on death, stroke, and MI, so only hard endpoints. And so that's the big difference with the 3-year analysis that we're talking about now.
Excellent. Thank you so much for going over that, and it makes a lot of sense. Now, moving on, Dr. Farron, could you briefly provide an overview of the results for the audience, particularly comparing the ACS versus chronic CAD, which is also one of the highlights of this paper?
Yes. So just as a reminder, FAME3 compared FFR-guided PCI with current generation DES to CABG, 1,500 patients. And it was a fairly broad inclusion criteria. Patients with a very recent STEMI were excluded, but otherwise non-STEMI and all ACS patients were allowed to be included. And so when we completed enrollment, 40% of patients presented with a non-STEMI acute coronary syndrome, and 60% had chronic coronary disease. And one of the first comparisons, that this was again pre-specified, we compared the outcomes of death, MI, or stroke in the ACS patients between CABG and PCI, and we found really no difference. They had very similar event rates at just a little bit below 12%. Whereas if you look in the chronic coronary syndrome patients, the PCI arm did about the same, also 12%, but the CABG arm did much better, only 7.5%. And so it actually was a significantly lower rate at 3 years of death, MI, or stroke in the CABG patients.
Excellent. Thank you so much for going over the results, Dr. Farron. And lastly, with this data now, what future directions do you see for research in this topic?
Yeah, it's a great question. I think there were 2 things that jumped out at us. One is, the similar event rate in the ACS patients, and that seemed to be because of an increased event rate early in the CABG arm. And some of that may have been due to delays to getting treated. If you look at how long it took to have CABG, it was significantly longer than to have PCI. It could also be due to some of the medical therapy they received, or it could be, just that they're higher risk patients and CABG is a riskier procedure in ACS patients. And so developing better techniques in the higher risk group could also help. So that was one key area to move forward on. And then the other is in the chronic coronary syndrome patients, the real difference seemed to be a much lower MI rate in the CABG arm compared to the CCS arm. That's what drove the difference, not death and not stroke. And so figuring out ways to reduce MI after PCI would be another important future goal.
Excellent. Thank you again, Dr. Fearon, for sharing these insightful results with us, and congratulations on your work.
Thanks. Thanks again for having me.
Thank you.